Imagine you're a detective. A patient walks into your clinic and says, "Physio, my shoulder hurts." Simple, right? Not really, because the pain could be coming from a tendon, a muscle, a joint, a ligament, a nerve, the capsule, or sometimes not even the shoulder at all. What? Today we are opening the shoulder files. Our mission to identify every major suspect behind the shoulder pain. Here's a fascinating fact. The shoulder is the most mobile joint in the human body. You can reach overhead, behind your back, across your chest, throw a ball at a high speed, or place your hand almost anywhere around your body. But this incredible mobility comes with a little trade-off. The shoulder sacrifices stability for movement. Think of balancing a golf ball on a tee. Yes, that's essentially what the glenohumeral joint is doing. And that is why shoulder injuries are so common. Most people think the shoulder is just one joint. It's actually a team working together. The glenohumeral joint, the acromioclavicular joint, and the sternoclavicular joint. Oh, let's not forget the scapulothoracic articulation as well. So, if one member of this team stops doing its job, movement becomes inefficient and symptoms can develop. Before we investigate the suspects, remember, when someone says shoulder pain, they are talking about an entire neighborhood, not a single structure. Suspect number 1, the rotator cuff. Meet the shoulder's security team: supraspinatus, infraspinatus, teres minor, subscapularis. How do you remember all that? Sits, yes. These muscles stabilize the humeral head while the arm moves. Without them, the shoulder loses control. Common conditions include rotator cuff tendinopathy, partial tears, full thickness tears, tendinitis, and muscle strains. So here's an interesting fact. Many people have rotator cuff tears visible on MRI, but experience absolutely no pain. That's why always remember, imaging should support clinical reasoning. Okay? Next, we have the labrum, a fibrocartilaginous ring that deepens the glenoid cavity and improves stability. Think of it as increasing the depth of an otherwise shallow socket. So, possible conditions could be SLAP lesions, Bankart lesions, labral tears, instability syndromes. Now, these injuries are especially common in overhead athletes such as swimmers, volleyball players, cricket bowlers, and tennis players. When a patient describes clicking, catching, or a feeling that the shoulder may slip out, the labrum becomes a prime suspect. Suspect number 3, the bursa and capsule. Now let's investigate two structures that frequently create stiffness and pain. First, the subacromial bursa. Now, its job is to reduce friction during movement. When irritated, it may contribute to painful overhead activities and night discomfort. Second, the joint capsule. When the capsule becomes thickened and contracted, we encounter one of the most frustrating shoulder conditions. These include adhesive capsulitis, commonly known as frozen shoulder. Now, one of the biggest clues, loss of both active and passive range of motion. Usually, the capsular pattern is affected, especially the external rotation. Suspect number 4, the bones and the nerves. The bones themselves can also be responsible. Fractures, dislocations, AC joint injuries, and degenerative changes. But here's where many clinicians get fooled. The pain is coming from elsewhere: the neck, the brachial plexus, or the irritated neural tissue. Conditions such as cervical radiculopathy can produce symptoms that perfectly mimic shoulder pathology. Now, that's why every shoulder assessment should include cervical screening. A shoulder complaint is not always a shoulder diagnosis. Patient says, "My shoulder hurts," your suspect list should include rotator cuff pathology, labral injuries, instability, bursitis, frozen shoulder, AC joint dysfunction, fractures, dislocations, nerve-related pain, and referred pain from the cervical spine. The challenge isn't finding a diagnosis. The challenge is finding the right one. Final message. So before we finish, our important reminder: this video is not intended to be a lecture on the shoulder. No single video can fully cover the anatomy, biomechanics, assessment, pathology, rehabilitation, and evidence behind this remarkable joint. The purpose of this episode is to appreciate the vastness of the topic, to understand how many structures are involved, how many conditions can be presented similarly, and how much clinical reasoning is required when someone simply says, "Oh, my shoulder hurts." In future episodes, we'll investigate each suspect individually through real patient cases and deeper discussions. Because every symptom is a clue, every patient is a mystery, and every great clinician is a detective.